Hello, this is Michael Altos, and we are starting our section on the endocrine system for pharmacology. This is lecture part 1. We will start by discussing medications used in the treatment of thyroid storm or thyrotoxicosis. The physiology is discussed more in the physiology curriculum. Remember that the first line treatment for thyroid storm is really supportive care, and that includes beta blockade. So a quick refresher on beta blockers. These are the first line therapy in order to achieve heart rate and blood pressure control in thyroid storm. The classic drug used is propranolol, which is a beta 1 and beta 2 non-specific antagonist. The normal dose would be 1 milligram IV given over about a minute, and you can repeat that dose every 2 minutes up to 15 milligrams maximum. Most of you, and myself included, have never seen IV propranolol and may never have the opportunity to give it. It's a little bit of an older therapy, and one of the reasons is because of its beta 2 action, which can cause bronchospasm in patients with COPD or asthma, in addition to the possibility of decompensated heart failure, which we would see with any beta blocker. But propranolol was classically the best choice. That beta 2 activity may be the cause of hypermetabolic effects and heat production, so a beta 2 antagonist would be appropriate. And the beta 2 antagonism also inhibits peripheral conversion of T4 to T3. Nevertheless, a more modern alternative might be esmolol, which, as we know, is a much shorter acting agent, and it's better, especially in patients who you're concerned with heart failure, because it's more titratable. A typical loading dose would be 0.5 to 1 milligram per kilogram, and you could follow that with an infusion anywhere from 100 to 300 micrograms per minute. Our goal is to titrate that heart rate to below 100 beats per minute. And just as an aside, recall that other options for controlling heart rate and blood pressure are appropriate. So, for example, metoprolol, atenolol, or even calcium channel blockers may be options for managing patients with thyroid storm. The next category of drugs to discuss are antithyroid medications. And the goal here is to really inhibit production of new thyroid hormone. There are 2 drugs in this category. The first is propylthiouracil, also called PTU. The dose is 600 milligrams given orally or possibly rectally, and then maintained every 4 hours. This drug works by inhibiting synthesis of thyroid hormone, specifically T4, and it also inhibits peripheral conversion of T4 to T3. Remember that this drug does not inhibit release of created thyroid hormone from the thyroid gland. It only blocks production of new thyroid hormone. Note that the drug has to be given orally or via a nasogastric tube and perhaps rectally. It's not available IV, although people have written reports of crushing it up and putting it through a filter and giving it IV, but that's certainly an unconventional way of giving the drug. The main side effect you need to know about PTU is hepatic failure. And for that reason, it's not commonly used as a first-line agent, and we really reserve it only for patients in the first trimester of pregnancy for reasons that we will see in just a moment. The alternative to PTU now is methimazole, which is what most patients are given. The dose is 20 to 25 milligrams, again given orally. It is similar to PTU, although it has a longer half-life and a slightly slower onset. And one limitation is that, unlike PTU, methimazole does not inhibit the peripheral conversion of T4 to T3. The main side effect with methimazole is that it is teratogenic, which means it's not appropriate for pregnant patients, and that's why in the first trimester those patients are switched to PTU. A few other drugs that are included in the treatment plan for thyrotoxicosis include glucocorticoids, which we'll discuss in more detail shortly. Dexamethasone 10 milligrams or an equivalent dose of hydrocortisone would be appropriate to reduce thyroid hormone secretion and also inhibit peripheral conversion of T4 to T3. Digoxin has been used by some. It can help treat heart failure as well as maintain appropriate heart rate, especially in the setting of patients who go into AFib with RVR. And finally, inorganic iodide, which would be sodium or potassium iodide, a few drops given every hour orally. That's sometimes used to inhibit the organification of iodine and release of thyroid hormone. This is called the Wolff-Chaikoff effect. And so patients sometimes are given inorganic iodide in preparation for emergency thyroid surgery. It's unlikely that you will ever be in this situation. And if you ever were, it would be in consultation with an endocrinologist. The only thing to keep in mind is that since iodide is the actual substrate for thyroid hormone, you don't want to just be giving iodide to somebody who's hyperthyroid. You could actually make it worse. And so we usually start antithyroid drugs first, and then start the iodide, which ends up acting as a negative feedback mechanism, showing that there's an abundance of iodine, and therefore thyroid hormone should be, synthesis should be turned off. One last drug to discuss in the thyroid system would be drugs to treat hypothyroidism, and that would be levothyroxine or Synthroid, which is synthetic thyroid hormone replacement. This drug binds to receptors in numerous cells, just like regular thyroid hormone does, and it increases basal metabolic rate by 60 to as much as 100%. This regulates energy use and enzyme transcription. It increases heart rate as well as contractility. The onset of action for thyroid hormone is 6 to 12 hours with a peak effect in 10 to 12 days and a half time of 7 days. So as you can see, this is a very slow onset and long-acting medication, and therefore it's not a problem if patients skip their morning dose, or even if they skip several days post-op if necessary. After about 5 days, we should really have arrangements made for IV Synthroid administration. An overdose of levothyroxine will mimic hyperthyroidism, so we expect to see all of those signs and symptoms: heart palpitations, maybe abdominal pain, nausea, tremor, anxiety, confusion, insomnia, weight loss, and increased appetite. A severe overdose would look like thyroid storm, so fever, hypoglycemia, and even heart failure and coma.
Glucocorticoids. Also called corticosteroids, the glucocorticoids are produced by the adrenal cortex and are also called cortisol. The role of this substance is anti-inflammatory, and there are cortisol receptors distributed widely throughout the body. The body secretes cortisol endogenously at a rate of about 20 milligrams per day, but secretion goes up in response to stress. Cortisol has anti-insulin effects, so it leads to gluconeogenesis, inhibition of glucose utilization, and hyperglycemia. There is a vascular smooth muscle response to catecholamines, which means that you can maintain vascular tone in the setting of stress when you have cortisol present. There's also a mineralocorticoid effect, which means that there is some aldosterone-like effect, retention of sodium and excretion of potassium. Why would we give a patient exogenous glucocorticoids? The first answer would be in a patient who has Addison's disease, a glucocorticoid deficiency. Second of all, we may use them as a stress dose corticosteroid supplementation, and we'll discuss that in a few minutes. Patients with asthma can benefit from glucocorticoids because of their anti-inflammatory effect. We usually start with inhaled steroids, and you may see drugs like Asmacort, Beclovent, Flovent, Pulmicort, or Advair, which all have inhalational steroids. The advantage of this is we get a local effect and less systemic absorption. The glucocorticoids can pool in the back of the pharynx, and if this is significant, it can lead to voice changes like dysphonia or even candidal overgrowth. Severe asthmatics may require systemic steroids, usually for an acute exacerbation. That would be 1 to 2 milligrams per kilogram of cortisol IV or another equivalent, 1 to 2 hours before anesthesia. I've never had to do this personally. Dexamethasone is another glucocorticoid. At a dose of 4 milligrams IV, we know it's antiemetic, and as we said previously, there's some data that might support giving larger doses. We give it near the beginning of surgery. It may help prevent surgery-induced inflammation and also maybe increase the release of endorphins. It is as effective as ondansetron or droperidol. And as we discussed earlier, we need to consider the risks of hyperglycemia in diabetics versus the benefits of dexamethasone therapy. Dexamethasone can also be used in the treatment of cerebral edema. For this, we need larger doses, usually in the 10 to 20 milligram range. It's effective for elevated ICP that's due to any sort of global ischemic injury, and we use it to decrease cerebral volume for intracranial surgery. We also use dexamethasone to treat post-intubation laryngeal edema. So if a patient has traumatic intubation or other airway trauma, dexamethasone can be used at a dose of 0.1 to 0.2 milligrams per kilogram IV. Glucocorticoids are used for a wide range of other anti-inflammatory conditions: postoperative pain, lumbar disc disease, collagen diseases, arthritis, skin disorders, ulcerative colitis, and acute spinal cord injury. They're also used for their immunosuppressive qualities in patients who are receiving a transplant. You may also see them used in patients who have respiratory distress syndrome, leukemia, myasthenia gravis. So whenever you see a patient who has any of these different conditions, you should evaluate whether they have recently or currently been given glucocorticoids. Now let's talk about the side effects of glucocorticoid therapy. We know that patients have the HPA axis, the hypothalamus, pituitary, adrenal cortex axis. We see that the hypothalamus secretes corticotropin-releasing hormone, which goes to the pituitary and stimulates release of ACTH, adrenocorticotropic hormone, which goes to the adrenal cortex and secretes cortisol. Cortisol then goes and provides negative feedback to the earlier stages in the HPA axis. So it turns out that exogenous glucocorticoids also have negative feedback on the HPA axis. When patients receive chronic exogenous glucocorticoids, they can develop adrenal atrophy and impaired ability to secrete cortisol in response to stress, illness, or surgery. When these patients subsequently are stressed, they have a risk of developing cardiovascular collapse, which is acute adrenal insufficiency. How long does it take after stopping exogenous glucocorticoids? How long does it take for the HPA axis to fully recover? Well, this is variable, and it depends on the dose of the glucocorticoids and the timing and the duration of therapy. So if a patient has a suppressed HPA axis, and we want to determine how severe it is, there is a way to evaluate the HPA axis. We don't really do it in the preoperative setting because it's just not feasible. But we can do what's called a random morning cortisol. And if the morning cortisol is greater than 10, that tells us that their adrenal gland is working pretty well. If it's less than 5, it tells us that probably their adrenal gland is impaired. And 5 to 10 is what we would call equivocal. A stimulation test can also be done, called an ACTH stimulation test. The patient is given an IV dose of ACTH, and 30 minutes later, the serum cortisol is measured. And greater than 18 mics per deciliter suggests that the HPA axis is intact. Now, since we can't always evaluate the HPA axis, in fact, we usually can't, we need to make an assessment on the day of surgery whether a patient is likely to have a suppressed HPA axis or not. Some patients are very unlikely to have HPA suppression. Patients who are on less than 5 milligrams per day of prednisone, regardless of how long, or 10 milligrams of prednisone every other day, or any dose of glucocorticoid if it's been less than 3 weeks. And even if it's been within the past year, at these low doses or low durations of time, we don't worry about the HPA axis. If they're still on prednisone, we give them their normal daily dose, and no further dosing or evaluation is required. On the other hand, we have patients who are very likely to have suppression. These are patients who take more than 20 milligrams a day of prednisone for more than 3 weeks, or a patient who's on glucocorticoids and has clinical evidence of Cushing's syndrome. These patients should probably get stress dose steroids in the perioperative period, depending on the magnitude of the stress that they're going to receive. And we'll see a discussion of that in just a moment. Most of the patients are in what we would call an intermediate risk, where their suppression is unknown. These are patients who are on 5 to 20 milligrams per day of prednisone. And just a reminder that prednisone, or rather steroids in general, are diurnal. They follow a normal circadian rhythm. So a patient who gets less than 5 milligrams every evening may disrupt their normal diurnal variation and the way they respond to stress. Also, any patient who's suppressed or intermediate and has been treated with steroids in the past year, so what that tells me is that even if they have been off steroids for 6 months, but they were on a high dose for a long enough time, we worry that they could still be suppressed for up to 1 year. And so how do we approach these patients? Some people just wait and see. They watch and see if they have signs of adrenal insufficiency. Others treat anyway, because an evaluation isn't really practical. What about inhaled glucocorticoids or topical glucocorticoids or joint and spinal injections? They can actually suppress the HPA axis at high enough doses, although this is not common, probably more of a risk in children than adults. We know that fluticasone is especially higher risk than other inhaled steroids if patients take enough, and there are some topical corticosteroids that can cause significant suppression, using as little as 2 grams a day for more than 2 weeks. And guidelines exist for these. So when patients are taking more than 750 micrograms of fluticasone for greater than 3 weeks, for the other inhaled glucocorticoids, the threshold dose is higher. Again, people who are taking high potency topical corticosteroids who've had more than 3 injections in the last 3 months, and as always, any clinical signs of Cushing's syndrome would be a concern for HPA axis suppression. So let's just be clear. Why do we care about this? Because patients who have HPA axis suppression are at risk for adrenal insufficiency. Stress dose steroids prevent that acute adrenal insufficiency. And the more stressful the surgery is, the more they're at risk of going into acute adrenal insufficiency. Usually we use hydrocortisone. It's cheap and available and an effective stress dose steroid. There are lots of other steroids out there, but they vary a lot in how much anti-inflammatory and mineralocorticoid activity they have. Could you use dexamethasone? You definitely can. Just keep in mind that it doesn't have a mineralocorticoid effect, and patients may need some extra sodium chloride to help retain salt and water. Whenever we talk about stress dose steroids, I have to emphasize it's always in addition to their usual morning steroid dose. Here's an example of one approach to how you could consider stress dose steroids. This chart looks at procedures categorized as minor, moderate, or major stress. Minor are things like colonoscopies or maybe an inguinal hernia, a breast biopsy. Major would be cardiac or major thoracic surgery, and moderate would be most of the other things that we see in between. So if a patient is at high risk for adrenal insufficiency and they're having a major stressful surgery, usually we'll give them a large bolus of hydrocortisone as their stress dose, say 100 to 150 milligrams. And then bearing in mind that the stress of the body continues even after surgery is done, we may have a taper. So in this example, we're giving 50 milligrams every 8 hours for a day, then 50 milligrams every 12 hours for a couple days, and 25 milligrams every 12 hours for a couple days. On the other hand, even if a patient is at high risk but they're having a very minor surgery, we may choose to not give them any stress dose steroids. Not because the patient is at low risk, the patient is at high risk, but there's no stress to precipitate acute adrenal insufficiency. So we have to look at both of those variables before we make our decision. What would be some side effects that tell us patients are exposed to a lot of glucocorticoids? Well, we know that there are electrolyte changes. There's a mineralocorticoid effect, even from glucocorticoids. So we get that save sodium and P potassium effect. Patients develop a hypokalemic metabolic alkalosis. They can get edema, weight gain, and hypertension. We also see hyperglycemia, and then some of the classic physical signs like the buffalo hump behind the neck, the moon facies, the abdominal striations, and very thin tissue paper skin. Other side effects of glucocorticoids include osteoporosis, peptic ulcer disease, psychosis or steroid rage, depression, cataracts, immunosuppression, and subsequent infections. Finally, we have a chart here as a reminder of the different generic and brand name glucocorticoids that are available and their equivalent dosing. So we can see here a dose of hydrocortisone, 20 milligrams, is equivalent to a dexamethasone dose of just 0.75 milligrams. This gives us an insight into how very potent dexamethasone is, and when we give somebody 10 milligrams of dexamethasone, it's the equivalent of hundreds of milligrams of hydrocortisone. We also see sodium retention, which is sort of the mineralocorticoid activity. So if cortisol has an activity of 1, we can see some of our drugs, like prednisone and hydrocortisone, are very close to that with a relative activity of 0.8, compared to dexamethasone, which has virtually no mineralocorticoid activity, or fludrocortisone, which is almost completely mineralocorticoid. That's enough for this section. We'll stop here, and please do let me know if you have any questions.